Imagine a ticking clock, not on a wall, but inside your own chest. You've just survived a heart attack, the single most terrifying event of your life, a brutal reminder of your own mortality. And in the disorienting aftermath, your doctors tell you that the next 12 months are the most dangerous. Your own body, your own blood vessels have become a treacherous landscape, inflamed and highly sensitive, primed for another potentially fatal attack.
Now, what if I told you that for years, the standard medical playbook for preventing that second devastating event has been tragically, fundamentally flawed? That a simple, remarkably low-cost adjustment using two readily available drugs could save thousands of lives every single year, but has been inexplicably relegated to a backup plan?
Today, we are not just reporting on a study. We are unraveling a medical revelation that could and should rewrite the global rules of heart attack recovery. This isn't a story about a futuristic billion-dollar wonder drug. It's about two existing, inexpensive medications and a new, shockingly simple strategy that is forcing the global medical community to confront a very difficult question. Have we been letting patients down at their most vulnerable moment? This is the story of a groundbreaking investigation from Sweden and the United Kingdom that exposes a critical, systemic delay in treatment. A delay that is measured in weeks, but whose consequences could be costing lives every single day. In this deep dive investigation, we will pull back the curtain on the science that is shaking the foundations of cardiology. What exactly is this powerful drug combination that can turn the tide against the world's #1 killer? Why have established medical guidelines, the very documents doctors trust, actively discouraged this life-saving approach for so long, favoring a slower, less effective path? We'll meticulously unpack the staggering numbers from a massive, real-world study involving over 36,000 patients, numbers that prove, beyond a shadow of a doubt, that we can and must do better. And most importantly, we'll uncover how this new knowledge is already sparking a revolution in clinical practice, offering tangible hope and a healthier, more secure future to heart attack survivors and their families everywhere. To truly grasp the significance of this breakthrough, we first need to face the enemy, not as a statistic, but as a biological process unfolding within millions of bodies. A myocardial infarction, the clinical term for a heart attack, is the catastrophic result of a long, silent war. For years, the villain of this story, a molecule called LDL cholesterol, has been on the attack. Often called the bad cholesterol, LDL is less like a simple substance and more like a biological vandal. It deposits fatty, waxy plaque onto the pristine inner walls of your arteries, the vital highways that carry life-giving oxygenated blood. Think of it as a slow, insidious process of rust and sludge building up inside the most critical pipes of your home. Over time, this plaque hardens, narrowing the arteries and making them stiff, a condition known as atherosclerosis. A heart attack occurs when one of these plaques suddenly ruptures. The body, perceiving an injury, rushes to form a blood clot to patch the damage. But in a narrowed artery, that life-saving clot becomes a life-threatening blockage, choking off blood flow to the heart muscle, which begins to die. For those who survive this brutal event, the battle has only just begun. The first year post-attack is a period of immense vulnerability. The heart is scarred, and the entire cardiovascular system is in a state of high alert and inflammation. The remaining arterial plaques are unstable and dangerously prone to rupturing again. Therefore, the emergency mission after a heart attack is to aggressively lower LDL levels to pacify this volatile internal environment. For decades, the frontline soldier in this war has been a powerful class of drugs called statins, and statins are legitimate heroes. They are proven to lower LDL cholesterol, reduce inflammation, and protect blood vessels. They have saved an untold number of lives. But here lies the critical, often overlooked flaw in the strategy. For a huge number of patients, statins alone are simply not enough to win the war. This is where the standard medical playbook, the one followed in hospitals from London to Los Angeles, begins to fail the very people it's designed to protect. Current guidelines, etched into medical textbooks and protocols, recommend a slow, dangerously patient, sequential approach. Imagine this typical patient journey. Let's call him John.
John, a 55-year-old, survives a heart attack. He is discharged from the hospital with a prescription for a statin and a mountain of anxiety. He is told to come back in 6 to 8 weeks for a follow-up. At that follow-up, a doctor will check his cholesterol levels. If the statin, on its own, hasn't been working well enough, if his LDL target hasn't been reached, only then will a second drug be considered. That second drug is called ezetimibe. Think of ezetimibe as the essential, game-changing sidekick. It works through a different mechanism than statins, ingeniously blocking the absorption of cholesterol from your diet in the intestine. The two drugs together are a formidable, synergistic team, attacking the problem from two different angles. But the core problem is the timing. This step-by-step process creates a gaping window of risk. Weeks, often months, can pass before John gets that crucial second medication. In that entire time, his LDL levels remain dangerously elevated. He is living through the most high-risk period of his life with incomplete protection. Researchers have a gentle academic term for this systemic failure: clinical inertia. But what it really means is a deadly reality where patients get lost in a complex system. Follow-up appointments are missed, work and life get in the way. Prescriptions aren't filled or renewed. People literally fall through the cracks of the healthcare system, all while that metaphorical ticking clock in their chest gets louder and louder and louder. But what if we could silence that clock? What if we could shatter this old passive model and replace it with something immediate and powerful? This is the revolutionary question posed by a brilliant team of researchers at Lund University in Sweden, in collaboration with the world-renowned Imperial College London. They decided to challenge the status quo, not in a sterile lab, but in the chaos of the real world. They embarked on a massive, retrospective study that was breathtaking in its scope. They didn't just look at a few dozen carefully selected patients. They analyzed the anonymized health data from 36,000 individual heart attack patients, drawn from the comprehensive Swedish National Health Registry over a 7-year period, from 2015 to 2022. This wasn't a theoretical model. This was the collected experience of 36,000 real people with real lives and real outcomes. They meticulously divided these thousands of patients into 3 distinct groups, representing 3 different treatment philosophies. The first group received only statins, the old established standard of care. The second group received a statin first, and then ezetimibe was added later on, following the conventional delayed approach. But it was the third group that held the key to a new future. This group was given both the statin and ezetimibe at the same time, right after their heart attack, within the first 12 critical weeks. No waiting, no sequential testing, just immediate, aggressive, comprehensive combination treatment from day 1. The results, published for the world to see, were not just statistically significant, they represented a paradigm shift in thinking. The patients who received the early combination treatment fared dramatically, unequivocally better. They reached their target LDL cholesterol levels far more rapidly than everyone else, and the downstream effects on their health were profound. This proactive group experienced significantly fewer subsequent major adverse cardiovascular events, like another heart attack or a debilitating stroke, and most critically, a lower rate of death. It was a clear, unambiguous victory for a simple, proactive strategy. It's a stunningly simple solution to a devastatingly complex problem. If you believe this kind of evidence-based research is vital for improving our healthcare, take a moment to hit that like button to show your support for the scientists doing this life-saving work. Let's truly absorb the real-world impact of these findings, because the statistics are not just numbers on a page, they represent human lives. Based on their meticulously gathered data, the research team was able to project what this simple change in practice would mean on a larger scale. Their calculations predict that for every 10,000 heart attack patients who are given this early combination therapy, about 133 major cardiovascular events could be prevented over the course of just 3 years. That's not a line on a graph. That is 133 families spared the agony of another emergency room visit. 133 individuals given a new, healthier lease on life, able to return to their jobs, their hobbies, and their loved ones. Now, let's zoom out and apply that same math to a single country. Let's take the United Kingdom, where the National Health Service deals with roughly 100,000 hospital admissions for heart attacks every single year. 100,000 people every year facing that terrifying uncertainty and the long road to recovery. Implementing this early combination therapy as the new standard of care, according to the researchers' conservative estimates, could prevent around 5,000 heart attacks over the next decade. Let that sink in. 5,000. That's not a rounding error. That is 500 preventable tragedies every single year. It is a stadium full of people. It is an entire small town's worth of lives saved, of families kept whole, of futures that are not cut short. And this is just in one country. When you imagine the impact on a global scale, where heart disease reigns as the #1 killer, the potential number of lives saved becomes almost too large to comprehend, all stemming from a simple, proactive change in how we use two existing, affordable drugs.
At this point, you are likely asking the same logical question that the researchers themselves have been posing to the medical establishment. If this approach is so profoundly effective, so obviously superior, then why on earth isn't this the universal standard of care already? The inertia is propped up by two main pillars of resistance. First, as we've discussed, the official guidelines written by medical authorities simply do not recommend it yet. Medical practice is a massive ship that is notoriously slow to turn, often tethered to guidelines that can take years, sometimes even a decade, to update, even in the face of overwhelmingly compelling new evidence. The second reason is a more general and sometimes well-intentioned caution among physicians about the concept of polypharmacy, or giving too many medications at once, especially right after a major health event. There are concerns about over-medication and the potential for side effects, but here is where the argument for the old, slow way completely disintegrates under scrutiny. The researchers, led by voices like Professor Kaushik Ray from Imperial College London, provide a powerful rebuttal. They are quick to point out that ezetimibe, the second drug in this combination, is an incredibly well-tolerated medication with a very low side effect profile. It is a safe and gentle partner to the more powerful statins. And then there's the elephant in the room, the cost. Professor Ray emphatically stated, these are two low-cost drugs that are already available. Ezetimibe is not some experimental, astronomically priced gene therapy. Its patent has expired, and it is available as an inexpensive generic drug. The financial cost of adding ezetimibe from day one is minuscule compared to the monumental cost of treating a second heart attack. The ambulance ride, the ICU stay, the long-term rehabilitation, the lost productivity. The argument against using it early is not based on patient safety or on sound economics. It's based on institutional inertia. It's based on clinging to an outdated model that this powerful new evidence proves is suboptimal and tragically, potentially deadly. And this isn't just a hopeful theory waiting for future implementation. The revolution is already quietly beginning. Dr. Margaret Leosdottir, the senior author of the study, and her colleagues did not just publish their findings and move on. Her own hospital in Sweden has already completely overhauled its treatment approach based on this evidence. They have put new, streamlined systems in place that empower and encourage doctors to prescribe both medicines early, making it the default combination for nearly all heart attack patients. And the results on the ground are a stunning validation of the research. In her hospital, twice as many patients are now successfully hitting their critical cholesterol targets just 2 months after their heart attack. That's double the success rate. Double the number of patients whose risk is being properly managed. That is a monumental, real-world improvement in patient care that is happening right now. And this success is contagious. The word is spreading. Other hospitals in Sweden and across Europe are taking notice and beginning to adopt similar proactive strategies, reporting their own positive results. This is the very essence of how medical science should work. New evidence, rigorously tested, leading directly to better, smarter, life-saving practices. If you want to stay ahead of the curve on critical health breakthroughs like this and be the first to know about the science that could change your life or the lives of those you cherish, make sure you subscribe to our channel and ring that notification bell so you never miss a vital updates.
So, what is the ultimate takeaway from this powerful story of discovery and change? It is a message of profound, actionable hope and a clear, urgent call for a global shift in medical practice. We are sitting on a simple, safe, and profoundly inexpensive solution that can prevent thousands upon thousands of repeat heart attacks and save countless lives. It doesn't require a new invention, a new technology, or a massive new investment. It simply requires a shift in mindset, a collective decision to move away from a slow, passive, reactive approach and embrace an immediate, aggressive, proactive strategy that gives patients the best possible defense right when they are at their most vulnerable. As Professor Ray aptly noted, this isn't just better for patients, it's smarter for our strained healthcare systems, reducing the immense financial and human cost of treating preventable secondary cardiac events. The affordable and widely available drug ezetimibe needs to be promoted from a forgotten backup player to a starting member of the team, brought into the fight from day one. This research empowers all of us. It empowers patients to ask their doctors more informed questions, and it empowers the medical community to adopt a new, evidence-based standard of care that could fundamentally change the future of heart health for millions of people.